Thank you very much for the introduction. So I'm going to share some of the things that we have been doing with the NIH Fund, and we call this HIV and Hepatocellular Carcinoma project, H2U project, and the H2A project. We started with one and ended up with another one, basically looking at viral hepatitis and some other causes of hepatocellular carcinoma. So in this overview, I say we wanted to look at clinical presentation and survival, etiologic factors, identifying those at high risk for liver cancer and screening for HCC. And all these were actually emphasizing the effect of HIV. But in addition to that, we're also looking at strategies for cancer interception, strategies, barriers, and opportunities of HCC control. We had a very extensive discussion this morning, those who missed, led by Mark about HCC. So this is a collaboration between Johns Hopkins in the US and Makerere University in Uganda to set up what we described as Center of Excellence for HCC studies in Uganda. And we had two projects. So the first project was a case control study, and the second one was a liver cancer screening study. And we also, of course, had the developmental and biomarker cores, funded by UCI U54. So in the case control study, we recruited a number of patients with liver cancer. Unfortunately, as you will see, very sick patients actually. And we had controls, again, from attending these hospitals with the trauma, general dental, ENT clinics. We had standardized evaluation, including questionnaires, clinical exams, focused on measurable liver disease stigmata and abdominal ultrasound scanning, and several laboratory tests and repository as well. We recruited 600 cases and 1,200 controls. And in these, we defined liver cancer based on clinical suspicion, ultrasound examination, alpha-fetoprotein, and in about 20% of the cases, we also had histopathology. The controls were, of course, free of liver cancer. We followed these participants 1, 3, 6, 12 months. But as you will see, this follow-up was basically on contacts, phone contacts of the patients and caregivers, which we recorded at the very beginning. And in cases where we were not able to reach the persons, the patient or the caregiver, after 3 attempts, we had our staff do field tracing. Now, of course, this is the depressing part. These are very young persons with liver cancer, most of whom are infected with hepatitis B. And 18% of the participants actually had HIV as well. And some were known earlier to be having HIV and were on treatment with ART, others were not. And for those with HIV, we had viral suppression rate of 77%. Okay. So it's not moving anymore. All right. So as you can see, these patients, if you look at the symptoms, they were already very sick. Majority of them weight loss, abdominal pain, and this is typical of what you will see in BCLC-D. as well as the signs, very sick participants, abdominal tenderness, hepatomegaly, and this, even if you stratify them by HIV status, there were no big difference actually in the presentation. And most of them, over 80%, had already multifocal disease with very few eligible for potentially curative treatment, which also we didn't have, actually. A few of these patients were able to receive sorafenib, but the majority of the patients couldn't get the medicine because they also have to buy the medicines. And the majority had already cirrhosis. In terms of survival, you can see from this, generally it was very poor. Survival was really very, very poor. Even when we stratify them with HIV, most of them were not able to live for long. Overall median survival from diagnosis was 42 days. And 91% were gone by 12 months. So very sick patients. We looked at the infections and HCC risk. Hepatitis B, hepatitis C, and you can see cystosomiasis. I think the number of people here who may not think that cysto can actually cause HCC. But this is what we got. In our country, we have 25% of the population infected with cysto. And so we actually wondered, when we tried to analyze this data based on the risks, cysto contributed 2.6 times risk for HCC, and hepatitis B 24 times. And when you combine cysto and hepatitis B, this was multiplicative, up to 68 times. So very difficult. Initially, we found it also difficult to understand, and we're wondering, what is the mechanism of cysto interacting with hepatitis B? And that is one other thing now we are trying to study. So we can successfully recruit patients, cases, and controls, and most of our patients with advanced disease, with rapid mortality, and the HBV and cysto interact to increase HCC risk. Then we had the screening study. So this was basically HIV. We recruited, we identified 2,000 HIV-infected patients, evaluated them for risk of liver disease progression using questionnaires, clinical exams, fibroscan, and laboratory tests. With them, we identified 400 patients with either hepatitis B or C or high TE elastography scan. And we followed these persons 6 monthly with alpha-fetoprotein and abdominal ultrasound scan. Now this, we actually managed to get 345 that we followed. We had 44 participants who had liver lesions, but not all of them had liver cancer. Hemangiomas, we had non-specific liver masses, cirrhotic nodules, and so on and so forth. But in 8 years of follow-up, we got 7 patients with the liver cancer. And so 4 of these had HBV. More than half of them actually had a fibroscan score of more than 12. So when we looked at the clinical and socio-demographic associations of fibrosis, it was mainly hepatitis B and HCV that was driving fibrosis in these patients. ART and biologic associations with liver fibrosis, we found that those who are ART naive at the time of recruitment, there was increased risk of fibrosis. And this risk was modified by ART, and this would depend on how long the persons were on treatment for HIV. And HBV active ART was protective, increased risk with the HBV DNA of more than 10,000. So we recruited these persons, and we thought if you achieve functional cure, probably you would moderate the risk of fibrosis in these patients, especially in HIV-HBV infected patients. And I think, let me go to next. So we thought about cancer interception strategies. So we thought if we are able to treat HBV, HCV, and HIV and cysto, we may be able to intercept HCC. And so when we got refunded for this by the NIH for this project, we expanded this to include Senegal as well. So we now called it H2A consortium, which is HIV and Hepatocellular Carcinoma in Africa. So, sorry. So this has been ongoing. What we did was to look at the HBV cohort and balance this between East and West African sites and the HIV status. And we performed similar evaluations as was earlier on with the screening study. And we managed to recruit 1,400 participants. Now, this is ongoing, and we do not have all the data yet that we can present here. The fourth project was a mechanistic study. Now we are looking at the cysto and hepatitis B. And so these were participants from the cohort selected for detailed investigation with paired blood and liver biopsy samples to try to understand the mechanism by which HIV, hepatitis B interacts with the cysto. And so we intended to get at least 200 participants, 25% with HIV co-infection. And the investigations we planned to do was peripheral and liver immunological studies, HCC oncogene studies, and also viruscape studies. So far, we have conducted 45 biopsies in these participants. Okay, so what are the barriers in SCC control in Africa? There are many. And if we can overcome these barriers, probably we'll be able to make a change. Vaccination uptake, screening of adults and the ANC, production and delivery of the antivirals. We still have challenges with getting antivirals, even in Uganda, for hepatitis B. Improving the algorithm for treatment and better screening strategies to identify those at higher HCC risk, delivery of curative treatments in patients who are diagnosed early with HCC. This is tough because we don't have the capacity to actually manage these patients. Palliative care for advanced HCC patients and overburdened healthcare systems. So, in conclusion, we know a lot about the etiology of HCC, the role of cofactors. We are still trying to pursue this. There's emerging data which appear promising on improved biomarkers and screening approaches. Curative treatments, both in terms of efficacy and availability, remain quite elusive for us in Africa. HIV care provides both a model and infrastructure to expand HCC control. We need resource and social mobilization to scale these efforts. Thank you very much for listening.